Welcome. Thank you so much, everyone, for joining us this evening for this follow-up to Professor Lambert's superb webinar with us a couple of weeks ago. We're delighted to have him back again to answer all your questions. Many of them were sent in both afterwards, and it was also an overflow from the webinar itself, but actually we have about 15 or 16 pages of questions that Professor Lambert kindly answered, which have already been posted under our long COVID link on the webpage. So I'll be posting the link to that in the chat in a moment. I'll just mention that any further questions that you have, do pop them into either the chat or the Q&A, and we'll be going through those as well. So just to mention a little bit of background, though I know you'll already be very, very familiar with Professor Lambert. He is a professor at the UCD School of Medicine, that's University College of Dublin, and he's an infectious diseases consultant at the MMUH, which is the Mater Misericordiae University Hospital in Dublin. He'll be telling us a bit more about that. And he has over 25 years of experience working in HIV, hepatitis C, STIs and other disease areas, and a long, very, very impressive CV, which was sent out with your registration. So I won't go through it all now, but welcome to mention anything else further that you'd like to, Professor Lambert. And otherwise, thank you so much for taking time out of your busy schedule to join us this evening.
Okay, well, thank you. And just to summarize, I took on Lyme disease about 10 years ago in Ireland, just because no one else was, and I knew quite a bit about it because I trained in America. And when long COVID came along, I saw a huge number of similarities in terms of the symptoms that patients with long COVID, long Lyme had. And then, to be perfectly honest, I knew very little about ME/CSF, except it was some kind of a post-viral condition. But when you actually kind of look at all three, there's lots of similarities. There's some kind of infectious agent stimulates this inflammatory autoimmune process in the brain. And unfortunately, what's happened over the years is all of these conditions have been, people have said, do graded exercise, which is the absolutely wrong approach, because people crash. Or they say do CBT, do some kind of cognitive behavioral therapy, kind of implying that it's some kind of psychiatric condition. But it's clearly not a psychiatric condition. And if you do your homework and look at the literature on ME/CSF and chronic Lyme and now long COVID, there, and look at the brain scans, there's abnormalities there, so there are it's an organic condition. It's not a psychological condition. So that really is the, is kind of where I started. And then finally, having watched my long COVID patients for a year in the first wave, bringing them back every 3 months, some of them just never got better. And this is the reason I started looking at some potential interventions that might speed up their recovery, because it's going to take years and years and years with all of the bureaucracy and inertia and, sometimes misguided, kind of funding of research to really come up with solutions that I think are going to help many of the long COVID patients. So I'll stop there.
No, thank you so much. I'll just go through the questions that I have here, and more are already beginning to come on the chat. So you talked about LDN last time, low dose naltrexone. How long would you recommend that a person should stay on it? Is it a long-term medication, possibly for life, or how would someone know when to come off it?
Well, this is the challenge, you know. I mean, that can you hear me?
Yes, can do.
Okay.
Yes.
Well, first off, LDN is a very safe product, so I guess that's the one thing. So there's no downside to taking it longer. My goal when I start people on treatment is to get them eventually off treatment, but everybody's different, I think, in terms of, you know, what happens. So originally, when I started patients with long COVID on LDN, I basically said, well, take it for 6 months, you know, gradually titrate up and then stop it after 6 months. But actually, you know, quite often I would get an email or call saying, within a few days of stopping it, the symptoms started coming back again. So I just think that that really is really is the answer. If you're not better or not back to where you want to be, then I would continue on the LDN. If you think you are 100% better, you know, after, you know, recuperation, rehabilitation, convalescence, then I think, you know, I advise people to gradually backing off of some of the support that they're getting, you know, one at a time, and then try to wean off, then try to stop the LDN. Probably one of the last things to stop, because I think it's one of the, you know, LDN has certain anti-inflammatory effects in the brain, and LDN has certain immune modulating effects to repair the immune system, you know, and I think that is the crux of long COVID.
Right. Well, another attendee says, I'm interested in knowing how to get hold of LDN. I mentioned it to my GP, but she knew nothing of it.
Right. Well, you know, unfortunately, I really don't. I'm really not part of any networks that are involved in this. There is kind of an LDN trust in the UK that I'm aware of, and they run an international conference every year. They have a conference coming up in, I think, June, being held in Pennsylvania this year.
Mm-hmm.
And they do have a list of doctors who are LDN prescribers, you know, so that's the best information I can give you.
Okay, thank you. Do you think that or know that long COVID causes lupus-like autoimmune conditions that can affect the skin?
Well, you know, I think I'm seeing patients with long COVID with, you know, I automatically at basic initial screening do a whole battery of autoimmune tests.
Martin, have we lost Professor Lambert for now, or is this just me? Sorry. Sorry, Professor Lambert, we lost you there. Maybe you'd like to start from the beginning of the question. Yeah. I know you said your internet is a bit shaky where you are.
Yeah. So what I was saying is that you don't make a diagnosis of rheumatoid arthritis based on an autoantibody. You know, for example, pregnant women have, you know, low-level rheumatoid factor positive because of pregnancy. So I think it's quite common to have lots of autoantibodies, and it's common also. There's a certain, I think there's a certain immune dysfunction. I think there's damage to the lymphocytes, the white cells. I saw a patient today whose CD4 count with long COVID, their CD4 count is 350, which is very low. And, you know, if I showed that to one of my junior doctors, they say, oh, is this person of HIV or AIDS? Well, no, they've got long COVID. And what do lymphocytes do? Lymphocytes help you fight infection. Lymphocytes help you clear infection. And lymphocytes orchestrate your immune system. So lymphocytes are critically important in, you know, cancer surveillance, in antibody production, and also in allergic phenomena. So I think there's damage COVID causes damage to a really critical part of the immune system, the lymphocytes. And those lymphocytes are involved in this whole, so people get lots of skin rashes, more allergies than they had before, more food sensitivities than they had before. I think mast cell histamine issues. So I think it's, rather than saying the rash is like a lupus rash, I think there's all sorts of autoantibodies that patients with long COVID get. There's all sorts of allergic reactions they get that they didn't have before because they've got some kind of immune dysfunction.
Well, that makes sense. Thank you. I'm a chronic Lyme patient, and since having COVID twice, my temperature has significantly dropped, at times to under 35 degrees. Are you seeing this at all in patients? Is it possibly a reactivation?
Well, it could be, but then again, it could be, as a rule, I don't see hypothermia as being a part of Lyme disease. It's usually sweats and fevers. But with long COVID, we are seeing what you call, the parasympathetic sympathetic dysregulation. You're seeing autonomic instability. You're seeing thermoregulation problems. So I think it's probably more a function of long COVID induced vagus or sympathetic parasympathetic dysfunction that's affecting the temperature stability, would be my thinking from my understanding of the literature and the pathophysiology of this condition.
That's interesting. Thank you. I've had COVID twice. The first time I was very ill and it took me a few months to recover. This last time it was incredibly mild, but I've been left in a worse state than the first bout. Have you seen this much in others, and why would this happen?
Yeah, well, exactly. I think that's the issue, is that patients can get long COVID if they have a serious illness in the hospital, but they can also get long COVID just from having almost a mild, cough for 2 days, no hospitalization. I think the data shows that each time you get COVID, I think you're at higher risk. And why is that? I think it's what I said before. I think COVID makes a hit on the immune system. COVID makes a hit on the lymphocytes. And I think I presented previously in the original presentation, some of the data that we did on the analysis we did from our ICU, HDU in patients with reactivation of herpes viruses, back in the olden days, if you saw somebody with shingles, you say, oh, do an HIV test, right? That's what you do because they're immunosuppressed. And I'm seeing 33-year-olds with long COVID now with 3 episodes of shingles in 6 months, I saw a young nurse recently, and she said her whole family had COVID last summer, everyone, and she ended up with long COVID. But incidentally, the 11-year-old, who's fine now, broke out with shingles in the setting of COVID. And that's quite unusual. Like I said, usually when you think about shingles, you think about immunosuppression, you think of elderly people who are immunosenescent, their age is causing their immune system to be down. You think of people with HIV and AIDS. You think of people on immunosuppressives as getting recurrent shingles. So I just think that I think the underlying problem here is that each time you get COVID, I think it's doing some damage to the immune system, and some patients are getting recurrent infections. Some people are getting easy acquisition of new infections. People are getting reactivation of dormant infections.
Right. Thank you. What do you think of treating long COVID muscle and joint pain with duloxetine,
right? Well,
which has presumably been prescribed by this patient's doctor?
Right. Well, actually, I always think that an awful lot of the treatments that the doctors are giving are just putting band-aids on the problem very often, so I don't think that, so a lot of mood stabilizers, a lot of nerve blockers, for heart palpitations, beta blockers to slow down the heart, and I think most of the patients I see that go on a lot of these medications, there's a lot of collateral damage, so you have bad nerve pain. So by taking, the pain medicines, you do get less nerve pain, but your brain fog gets worse, or if you take, duloxetine and some of the other, psychiatric medications, then they do have some benefits, but they do have some side effects as well. And very often patients can't tolerate them.
Yeah, right. A couple of questions here relating to supplements and the cost of treatment. I'll just begin this first one. Considering the cost of supplements are prohibitive to some, and GP prescription and help is not always forthcoming, what could people do for themselves to support recovery?
Yeah, and that really is a challenge. I've just been talking to people recently, and people are paying hundreds of pounds and euros a month, when they can afford it, just for all of the supplements. But, I guess my simple solution is that, people, and I think I said this in the previous lecture, is that people with COVID, long COVID, are deficient in zinc, selenium, magnesium, coenzyme Q10. So it does make sense to try to replace that, and I think coenzyme Q10 is quite helpful. There are studies done to, kind of speed up recovery from long COVID with manipulating the gut, your microbiome. So I think, something as a probiotic, or, I go to the Polish stores in Ireland and pick up a liter bottle of kefir for €1.20, and it lasts me for a week, so I think that is a reasonable option. And then, finally, for some of the crashing that people describe, the N-acetylcysteine as a supplement you can get in herbal stores. And I think we had a discussion about N-acetylcysteine is used for children with inherited mitochondrial disorders, and they get extreme muscle weakness and crashing, and it's used in that setting. So I just think that if I couldn't, if I couldn't afford anything, I try to get a multivitamin with coenzyme Q10. I tried to get kefir, and I tried to get the NAC as a minimum. And then there's dietary things you can do. There's lifestyle things you can do that is not the solution, but it's, but it's part of the solution. So I guess I'll just stop there.
Brilliant, thank you. Well, that answers one other question, which was, what are the top 3 things I can do? I think that came out of that answer very well. Thank you. There's a relatively new study into the use of metformin being used for acute COVID, but the precise mechanism appears to be unknown. Could metformin also help long COVID? Have you used it or considered it?
No, I really haven't, and I can't really comment on the study because I haven't looked at it. I mean, people are grasping for straws for every new drug that comes along. And I think, like I said, I haven't seen the data on that.
No. And then another question relates to new research from Griffith University in Queensland, Australia, which I think was looking at the brain imaging of both long Lyme and long COVID and finding correlations there. Given that it states calcium is not being taken up, should this be added as a supplement, is the question.
Yeah, I don't think there's a cause and effect relationship between what they're finding, I presented on the PET scans, and the similarities between the PET scans and chronic Lyme and long COVID, and the MRIs and CTs that you can actually change the imaging and do this and do that to increase the sensitivity, and I think that's what they've done. So I just think that the techniques that they're using are probably if are going to make it easier for people to get scans done, right? Because PET scans are scarce, and CTs and MRIs are much easy to get. But if you do a standard CT and MRI, most times they're reported as normal. So the scans that they did have manipulated, I don't know what they've done. I did read the article, but they've kind of changed it around. So I think in the future we should be using the techniques that they used to be, because what happens many times is you have normal bloods, and they say that you have normal blood tests, and the doctors say your bloods are all normal, you're fine. You have a brain scan that's normal, everything's fine. So I think the more sensitive tests we have that show up the abnormalities, I think the more credibility, and the more acknowledgement the patients will get about the, support for their diagnosis.
Right. But I think a blanket sort of, yes, adding calcium as a supplement probably can't be derived from that study yet, in your
Correct.
opinion?
Correct.
Yeah. One patient here says she's 56, had her gallbladder removed at age 28. It was infected and full of stones. Will this possibly affect what food and supplements she can absorb? Especially, I'm sure she means in view of her long COVID now. Will this have a sort of particularly significant effect on her immune system?
I'm sorry, can you repeat the question? The fact that she's got gallbladder out.
Having had her gallbladder out, yes, she was not told that she needed any supplements or dietary changes at that time. And could this have a sort of doubling negative effect now that she has long COVID?
I mean, the issue is that long COVID affects the gut as well, so there is an effect on the gut. But what is the effect on the gut? And I think part of the effect is really, it's the innervation of the gut, it's the peristalsis, so it's the sympathetic, parasympathetic system. So I do think there are issues with the gut not working and the gut the innervation being damaged and stuff, but I don't think that should make a difference in terms of what you take in. You should be able to absorb it,
Okay. You were kind enough in the very, very long tract of questions that you answered that we've now put up on our website to go into a few that did touch on the vaccine. So I'll ask one here, but do say if you don't feel it would be appropriate to answer. She writes, my daughter is now 2 years with no monthly cycle. She was regular before her vaccine. She's only 15 now. Any comments on that?
Well, I guess I would say is that I still get back to the fact that there's a lot of similarities between the symptoms from COVID-induced long COVID symptoms and vaccine-induced long COVID symptoms. And what are vaccines? Vaccines are proteins that stimulate an immune system. And and when you stimulate that immune system, there's going to be inflammation. That's the end result. And if looking at people if you look at people with COVID, long COVID, I think a lot of the endocrine problems, a lot of the problems are CNS. You've got in your brain, you've got your pituitary, hypothalamus that signals downstream to the thyroid, to the male and female organs. So I do think that the best explanation for a lot of these endocrinological problems is it's the brain inflammation that's triggering the problem.
Yeah. And therefore using a lot of the therapies that you've already gone into, particularly in your first webinar here. Have you had any experience of using hyperbaric oxygen for long COVID?
Well, the thing is that in Ireland, you can get hyperbaric oxygen covered by many insurers if you have a diagnosis of chronic fatigue syndrome, but not if you have long COVID. Oh. But there actually is data that shows, hyperbaric oxygen can help patients with chronic fatigue. The issue is what's the mechanism of what's happening there, number one, and is it a permanent thing or is it a temporary thing? This is really the challenge. So I'm totally supportive of, hyperbaric oxygen. And I've read some of the literature on it for chronic fatigue syndrome, and there is evidence that it does help. And if you look at the concept of, hyperperfusion defects, that the whole part of the thinking of what's happening in the brain with long COVID, and some of the theories that there might be microclots and in the small blood vessels and lack of blood flow going to critical parts of the brain, you can make an argument that hyperbaric oxygen then is helping to overcome that. The question is it a temporary thing, or is it reversing the damage? That's the question. We don't know, but I'm fully supportive of it. I think I've seen it help people, with chronic fatigue syndrome. I've seen people with chronic Lyme go get it. I've seen people with long COVID go get it, and some of them have benefited, some of them have not, but there is evidence that it does help.
Thank you. That's helpful. A longer question here. In your experience, are those who got COVID in the first wave before vaccines were available taking longer to recover, or have some recovered? I'm 3 years in now, and my neurological and cognitive conditions are worsening.
Right. And I always say everybody's on a different trajectory. I wouldn't say that there's more that the first wave with Delta, people were more likely to be sick 3 years later, 2-3 years later. I don't think, I think all of the viruses are neurotropic, and while the first wave Delta, more people ended up in the ICU, and sick. It was more pathogenic. But I think you're just as likely to get long COVID if you had Delta or whether you had Omicron. And I don't think that we don't know. We don't really understand. I've got some people that were, sick, similarly from the first wave, from April, May 2020, who are still unwell. I don't think I'd get anybody who's getting worse. And the reason for that is because I don't just follow them and watch them. I actually try some interventions.
They're getting therapy. Yeah.
Now, unfortunately, not all of them are 100% better. That's the thing. The goal is to get them back to normal functioning. I have a number of nurses that were totally debilitated and totally unable to work at all. And over a period of a year, they're now back working 3.5 days a week, and when they try to go more than that, they crash. They crash again, so it's not ideal, because they were, working full-time, raising 3 children, involved in sports activities, so they're not back to where they were, but I do think that I guess I would say I wouldn't give up hope, but I think you need to be in a center that is providing support, not just seeing you doing endless tests and bringing you back without any intervention.
Absolutely, yeah. Have you seen many cases with inflammatory joint problems post-COVID?
Yeah, well, not so much. What I see is very much mostly kind of migratory joint pains rather than, than inflammatory joint pain, kind of similar to Lyme disease.
That's interesting, isn't it? Very similar.
Yeah. But then again, if you look at the pain centers in the brain, the pain centers are in the posterior part of the brain. So the pain centers are coming from there. So I have seen a few, I have seen a few cases of people getting, kind of swollen hands on and off and swollen ankles on and off. But I don't think I've seen a single isolated swollen, kind of joint with, suggesting a kind of an infection in there. I think that the pain is more kind of a migratory type pain that moves from one joint to another.
Okay, thank you. Ray, the vagus nerve stimulators that you mentioned in your initial webinar, do you have any specific ones that you would suggest?
Not really. I mean, I don't really know of the different companies that make it, but Herbalists and others have used, kind of vagal nerve stimulators, the transauricular vagal nerve stimulators for successfully for patients with gut problems, for patients with, hypomotile guts and stuff, just to stimulate the gut to get it working. So I think that, and that is one of the one of the problems of long COVID. The vagus, like I said, the vagus nerve is, we didn't know this initially. We thought it was cranial nerve 1 and 2, the smell and the taste. But a year ago, I think that, it became recognized that the vagus, probably every cranial nerve is involved with long COVID, but I think the vagus nerve is causing so many of the symptomatology that people are getting, the chest pain, the radiating pains coming through the chest, some of the swallowing problems that people are getting, and I think also some of the gut motility, alternating diarrhea, constipation, the bloating, people are getting hypomotal guts with huge swelling of the abdomen. So I do think it makes it makes sense that studies need to be done, but I think these transauricular vagal nerve stimulators, there's scientific rationale for how they would work, and they've worked for other diseases similar to what we're seeing with long COVID.
Right. You mentioned last time Sublime Vitality and Sublime Essential. Can they be taken together?
Yeah, they can. They're kind of focusing on different things, and I think that these products were kind of put together by, I work with a group of herbalists called Napier's the Herbalists in Scotland, and patients are buying 15 different herbal supplements, and I guess the advantage of some of these is that I think the Vitality has kind of about 34 different supplements. In Ireland, there's a product called Revive Active, and there's another product called Revive Mastermind, and I think the Sublime Vitality is both of those combined plus a few other ingredients, and it's if you take 3 or 4 of those, it's just as cheap to buy them all together. The Sublime capsules are kind of focusing on different things. They have the turmeric, the NAC, the resveratrol. There's a number of different ingredients that, and as I mentioned before, the NAC is kind of working on the crashing. So they're kind of focusing on different parts of the system. So yeah, they can be taken together.
Well, thank you. You mentioned some breathing exercises last time. Could you elaborate on those a bit more? And are they for vagal rebalancing? Right.
Well, they're really for, like I said, I think I included the link in my presentation, and actually these exercises were recommended by, there's an Irish Olympic rower who got really badly affected by COVID in the first wave, and she got absolutely no support. So she actually put together diaphragmatic exercises. She put together, breathing exercises to recondition the sympathetic parasympathetic system. Everybody knows that long COVID, people are getting these fight or flight, this sympathetic overdrive, the anxiety, the overstimulation, the oversensitivity, this kind of stuff. And this is and then I think a lot of the tachycardias, bradycardias, heart rate up and down, the thermoregulation, I think an awful lot of that is, sympathetic, parasympathetic. So the breathing exercises, which breathing, I think it's, 7 breaths in and then 10 breaths out, so you're kind of, that is a way of pushing the parasympathetic system. Now, I'm not an expert in this, but I'm just saying this is my limited understanding. But I think if you go to the slides that I had and go to the YouTube, reviews, there is data that this is not nonsense. It does work. There's and I think it makes a lot more sense to be doing this to control your heart rate than putting people on beta blockers, because if your heart rate's go up to 170, the beta blocker will keep it down, but beta blockers also slow your heart rate. And if your heart rate's running down to 36, you don't want a beta blocker to block it down even further. So that really is a danger. I think it's safer to kind of use some of these natural remedies than if you can, rather than some of the pharmacokinetics. And then beta blockers also cause a lot of CNS effects, cause a lot of problems in men with impotence. and in terms of these issues. So there's a lot of collateral damage from these agents.
Right. Well, the slides are under long COVID on our website, and also under past webinars. So you'll find them alongside the video. Should a CD4 count be routine, do you think, for long haulers?
Well, it probably doesn't change anything. I just think that, when you get a full blood count, it has, a hemoglobin, it has platelet count, it has a neutrophil and a lymphocyte. You'll often be able to see low lymphocyte counts just in the full blood count. This is the issue. I think sometimes it's good to get it just for acknowledgement that there's something going on. Like when I have abnormal tests, and not everybody has low lymphocytes, I would say about a third of people have low lymphocytes. It's not everybody has it. But when I have it, I give it to the patient, I send it to the GP, and I go, see, there's something there. This is not, you don't give them Xanax, for their low lymphocyte count. You can't, anxiety doesn't create a low lymphocyte count, It just kind of, for in a lot of ways, for me, it just legitimizes the fact there's something real going on.
Absolutely.
So I think it's an interesting research tool, but I'm not sure it helps me, in terms of, it helps me tremendously in terms of changing my therapy.
Right. A question here about whether you diagnose and treat MCAS, mast cell activation syndrome, and if so, how?
Well, like I said, I think it's just part of the people. Interestingly, back in the days of HIV and AIDS, this is tangential here. Before there was any treatment available, the sicker and sicker that somebody with HIV and AIDS got, the more allergic reactions they get, the more reactions to antibiotics they got that they never had before, the more they'd get swollen joints, they'd get, be catching all these other infections and stuff. So they had huge allergic phenomena as part of their advanced HIV and AIDS, so they get food intolerances, they got drug intolerances, like the normal population, 0.5% of people are allergic to cotrimoxazole, Septrum, Bactrim. With AIDS patients, it was 10%, and so much higher, and the more sick they got, the more allergic reactions they get to every antibiotic you gave them. So I just think that there's the part of the process of this immune dysregulation being caused by, by long COVID. There is mast cell histamine release issues. What do you do from that? I mean, nobody knows. I mean, common sense, it does make sense to, use H1, H2 blockers. People have tried those kind of things, although there's no good studies to prove that. The other thing is like I said, some of the ingredients in the sublime, according to the herbalists I work with, the sublime essential capsules, some of the ingredients there are focusing on the histamine, the mast cell released. So there are kind of herbal approaches to manage, histamine mast cell released issues as well.
Right. This same attendee says that as a result of being so sensitive, she's troubled by the fillers used in LDN. And she found it helpful to remove the microcrystalline. Presumably she got it compounded, especially. Is this something that you've noticed and consider?
I'm not aware of that. This is the first time I've heard that, but like I said, it doesn't surprise me. People become allergic to so many things, But that's also true. That's also true for a lot of Lyme patients with chronic Lyme. They have incredible sensitivities to the antibiotics, to the herbal products, to lots of the different agents that you give them. So there's something going on there as well.
Yeah. One attendee has put this note in here that NAC in Ireland is available on the medical card scheme, GMS, and under the drugs payment scheme.
Yeah.
And she's also heard that LDN is available on these schemes too, though individual approval must be applied for, i.e. a hardship application through the pharmacy. Is that something that one could point people to, or is it rare?
Well, the
to
thing
get
is,
that?
there isn't a national system. Ireland consists of lots of little fiefdoms of HSC executives all over the country who make their own decisions on a regional basis. So unfortunately, you know, some regions are able to get LDN, some regions are not, you know, free of charge. Same thing with NAC, but it's worth asking your pharmacist to, you know, to see if they can get NAC covered and get LDN covered. You know, and
well, that's a good tip. That's not possible in the UK as far as I know, but that's great then, that it might be possible. A question here, could you possibly tell us about your radio interview today that someone's heard you gave?
Okay, well, like I said, the issue, I think, is that we are delaying coming up with a plan for, you know, establishing centers that are fit for purpose to manage long COVID. And I think the ideal model moving forward would be have kind of a neuro-rehabilitation center with a variety of different specialists to support patients and specialties and people with different skill sets, you know, occupational therapists, physiotherapists, that really kind of focus on neuro rehab. And I think that center could really support not just long COVID patients, but also, like I said, the Lyme and the ME/CSF patients. But in the first wave of, you know, COVID, the NHS kind of put together centers that really kind of were pulmonary focused, and Ireland kind of carbon copied that and put together centers for pulmonary specialists and infectious disease specialists, and just one center for neuro rehabilitation for the whole country. And you know, and that really was a mistake. And that was a mistake when the whole program started. You know, we knew a year before that neuro rehab was the problem, but it seemed like what happens is governments are years behind, and by the time they put a plan in action, they can't change it. They can't change direction. You know, and the direction that I think both the UK and Ireland chose has really been it's really missed the mark. They've not really kept up with the science. And we did the original study that I presented to you was the Anticipate study, and we prospectively followed 150 people, and with questionnaires over a period of a year, 18 months, and about 10% of them were still unwell at a year. Subsequently, a group from Cork published on about 1,000, and they came up with the same results. And more recently, Scotland, about 6 months ago, published a study where they did an epidemiological study where they did questionnaires prospectively over an 18-month period on about 33,000 people, and they had about 60,000 controls, negative controls for COVID. So there's really robust data, I think, in Ireland and the UK and Scotland on, you know, on long COVID, how common it is. So Ireland just announced yesterday they're going to start their own local epidemiology study to see how common long COVID is in Ireland. And my response to that is, why? You know, I mean, why Scotland is not much different from Ireland in terms of the population, in terms of the, you know, the same genetic origin. So I think that doing another study, they announced that they're going to do it 6 months ago. Today, they announced they're starting it, and they say they're going to have some pilot results by September, October, and that will influence setting up long COVID clinics. But we'll be 3.5, 4 years into COVID by then. And it seems like an exercise in stupidity to be doing that, to be perfectly honest. So that was my comments on the radio, is that why do another study? Why not learn from the studies that have been done? And why not learn from the experience of other countries? Because all it's doing is delaying getting treatments, you know, to patients, and establishing centers that are fit for purpose.
Thank you so much. There are many comments here saying thank you for advocating on our behalf. You're our beacon of light. It's you know, brave and very, very helpful for you to be speaking out like that. Thank you. a couple of questions, which I think you've sort of covered already, but I'll just read them out anyway. Regarding vaccine-induced long COVID and whether it's treated similarly to long COVID from infection. Do you think the pathophysiology is basically similar in both? And would a study such as you've just described be able to assist both?
I'm not sure, to be perfectly honest. I'm not sure they're going to. I think they're only going to take people who have documented COVID infections. So it's not going to separate out the vaccine-induced long COVID from. They're only going to select people with PCR documented COVID. So it's not going to help.
But whether you think the pathophysiology is similar. I'll read out another question, which is, I have post-vaccination syndrome diagnosed by a neurologist in Glasgow. I won't read out the name. Following AstraZeneca vaccine 2 years ago. My symptoms mirror long COVID. What can I take or do to try to recover? So I'm presuming she hasn't been given any advice.
Exactly. And I think I kind of, some of my slides, basically, I've kind of put out in the public domain my approach to, I've not kept it a secret. I've kind of, if you look at my slides, I've kind of given my recommendation. But similarly, I do have a number of patients with vaccine-induced long COVID who are significantly better. And I think the thing that got them better more than anything else, to be perfectly honest, was the LDN, because like I said, I think there's inflammation, there's brain inflammation, there's immune dysfunction, and LDN's working on both of these. If you look at the history of LDN, I mean, neurologists have used LDN off license for years. Rheumatologists have used LDN off license for years. And there's one study that I kind of recall where patients with kind of atypical MS, not quite MS, but funny neurology and brain scans, MRI scans that showed white matter abnormalities, kind of T2 weighted, images. That's what they describe. And when they went on the LDN, 6 months later, they repeated the scans and the neurology had gone away and the brain scans had gone back to normal. So they're not great studies, unfortunately, but I just think that, that we do need more research. We need better research, but I would say that, LDN is part of the solution, and the patients that I've seen with vaccine-induced, kind of long COVID symptoms, I think it's the LDN that helped them.
Thank you. That's very helpful. Anything. Yeah. Another question here from a patient who has a pituitary cyst. I think she's wondering whether that could be partially activated by COVID. She's had it twice and also has fibromyalgia, but has suffered from shingles twice in the past and glandular fever as a child. Is it possible that this has all been reactivated and that the pituitary cyst is somehow there in the mix as well? She doesn't say when that was diagnosed. Yeah. The reactivation of viruses, most certainly, right?
Yeah, reactivation of viruses, absolutely. And kind of interestingly, if you kind of look, why is it that people get long COVID? I think if you look in people's history, you kind of see, oh, when I was 9 or 10, I had shingles, when I was a teenager, I kind of had a few months where I missed school because I had chronic fatigue. I had Epstein-Barr virus and I was out of school for 6 months. People have, there's something in people's immune system that kind of, I think, makes them at higher risk for getting long COVID. We don't really have a magic marker to predict that. But people with COVID, long COVID we're seeing, attacks on the thyroid. So we're seeing both hyperthyroidism and hypothyroidism. So, right. So I do think that there is attacks. So there's a possibility that there could be, similarly inflammation or target attack on these different, endocrine organs. Yeah.
Thank you. Yeah. Do you have any thoughts on the use of bakelin? That's an extract from Chinese skullcap to reduce primed microglia. This participant says it's a great antihistamine, supports beta oxidation, and is an immune system modulator. Have you heard of Chinese skullcap being used?
No, I haven't. To be perfectly honest. No, I'm not really familiar with it. But like I said, I think that these agents are, I think a lot of these products have been used for centuries. They're not toxic. And, I just think that I think that's probably it's probably a safe option to look at that kind of approach than some of the other approaches that it's an attempt to reverse the damage. So I think it's a good idea.
Yes, there was a question about lactoferrin as well. I don't know whether you've used that, whether that would be helpful. No,
I haven't.
There's a very sort of global question here, which you have answered over the course of the last sort of 3 weeks, but maybe I can ask it again because it's so interesting. What causes a person to develop long COVID after having a COVID infection? I mean, that's a big one, isn't it? And also, do people still get long COVID with the newest strains, which are apparently a lot milder?
Yeah. And the answer is, we don't know why people get long COVID, but I do think there's something that in somebody's immune system that predisposes them to it. So there's some not necessarily a clearly defined immunodeficiency, but there's often a history of something not quite right in the past, or a previous episodes of problems before. But we really don't know. And then, are you less likely to get long COVID now that you've got Omicron rather than Delta? I don't think that's panning out. And then, are you less likely to get long COVID if you've been vaccinated? That's also a question. And the benefit seems to be really minimum. I think one of the studies from America, the Veterans Administration study, I said that, you're 13% less likely to get long COVID if you've been vaccinated than if than not vaccinated. But that's a very small amount, 13%. So at best, there's a minimum benefit of getting vaccinated and being less likely to develop long COVID. And maybe there's a little bit more likelihood if you've got if you're seriously unwell and end up in the hospital, you may be a little bit more likely than to develop long COVID than if you're in the community with just a mild illness. But the difference is not really great.
Yeah, it's stunning, really, isn't it? How things have developed over the last 3 years. Have you seen many incidents of idiopathic hypersomnia with long COVID, whether from the infection or the vaccine?
Not really. I mean, most people I see is insomnia, people with horrible sleep disturbances. Yeah. I've seen one patient who has uncontrollable yawning, just yawning all the time. Yawning, people get uncontrollable coughing. Other kind of symptoms from cranial nerve inflammation, I think, but this was a new one, just yawning, uncontrollable yawning, all the time. So it's a new disease. It continues to surprise us all the time. The brain is signaling downstream all sorts of, aberrant neurological signals.
Absolutely, yeah. Have you found any medications or supplements useful for breathlessness, breathing pattern dysfunction? That's an important one, isn't it? I mean, of course, it's tied into everything you've already discussed. But
it probably is, and I think, and some of the, I did this rower that gave me advice on some of her exercises. I think some of the diaphragmatic exercises. I do think that people are not lose their ability to breathe. They're shallow breathing. They're not taking a deep breath. They have air hunger. So I do think it does there are exercises to retrain the diaphragm. But similarly, I used to always in the so many patients with this air hunger, breathing problems were sent to pulmonary doctors and put on asthma medicines, and getting pulmonary function tests left and right and CTs to the thorax left and right. Most of the time, it's not coming from the lungs, you know. Occasionally I've seen it worsening asthma or new asthma as a setting of COVID, long COVID, but most of the breathing problems, I think, is a central one. And as I stated, the posterior part of the brain, the respiratory center is there. So I think, you know, I've seen patients with breathing problems, their breathing problems totally disappear on LDN. LDN is targeting the brain inflammation. As you improve the brain inflammation, that air hunger disappears. Not in everybody, but I always say not one thing works for everyone, but I would say the response rate of LDN, I think about 80% of the patients I see have responded to the LDN in some capacity, but not everybody responds to any one treatment.
Fantastic, thank you. Actually, there is one comment here. Could you get some research into LDN going in the UK, maybe for ME, long COVID and fibromyalgia? Perhaps patients could purchase LDN themselves and complete a self-report survey or something. Everyone's finding, you know, what you're explaining about it, its mechanisms so valuable that could be worthwhile, couldn't it? I mean, you've already done that in your study, haven't you, at the Mater Misericordiae, but perhaps something broader based.
Yeah, no, the trouble is that, you know, trying to get funding for these things and you know, is very difficult. I actually proposed in Ireland that we do an efficacy trial of LDN to the kind of the national committee who are involved in long COVID, and basically it was just shot down. You know, all those studies have been doing elsewhere. You know, by the time you get it going in Ireland, the results will be out. You know, and so unfortunately, there's not a lot of interest in, you know, kind of the medical communities and the people who control the monies to do these kind of studies.
Maybe it could be suggested to the LDN Trust that you mentioned just earlier, that's having that conference this year in Philadelphia. We could maybe put in a request. One or two just last questions, because we're heading up to the hour, I think. I feel a lot of head pressure during crashes. Do you think it's beneficial to take aspirin or an anti-inflammatory to help prevent cognitive issues getting worse?
Right. Well, like I said, I think one of the we've talked a little bit about the hypoperfusion defects and the micro clots that may be part of the pathogenesis. And I think I did mention a study in America where they put people on triple anticoagulants. You know, the apixaban plus clopidogrel plus aspirin. And it does seem to benefit people, but the side effect was a couple of people ended up with massive intestinal bleed and one ended up with a bleed in their brain. So I do think that is kind of a risky strategy. But we use kind of, you know, for patients who have what I consider stroke-like symptoms. You know, I have patients with unilateral weakness or unilateral, you know, symptoms, you know, kind of similar to TIAs, you know, transient ischemic attacks. I think things like, you know, the nattokinase, things like low-dose aspirin, I think, you know, potentially does have a benefit long-term. I'm not sure just using it acutely in the setting of a crash.
Thank you. We have so many questions still pouring in that I'd like to ask Martin if you could save them, please, when this comes to an end, because we'll need to perhaps later. I'm sure now you don't feel after those 17 pages like answering further ones in writing, but we'll work that out. But maybe just one or two more. Here, someone has asked whether you still have appointments free. And that would be in both Edinburgh, I think, and in Dublin, right?
Yeah, and I'm seeing patients privately in both Edinburgh and Dublin. Unfortunately, as stated, I did have a public clinic in Dublin that was never funded, despite all my efforts and hard work. But I do see patients. I do continue to see patients privately in both of those locations, and I think on my slide set, it has kind of the emails, how to contact my secretary.
Exactly.
People are interested in appointments. Okay.
Brilliant. Thank you. Yeah. Well, we really are coming up to the hour now. So I think rather than going into further questions, some of which are very long and many of which do relate to either herbs or the mitochondria. I'd just like to mention that we do have a herbalist who will be speaking later in the year, and we'll be advertising that one. It may well be an idea for us to get Monica Wild over to speak to us as well, Professor Lambert, since you've mentioned that you work closely with her. And we will be having, right after Easter, another webinar on the mitochondria, and we'll make sure that we introduce the questions that overlap with long COVID, as many of them do there. So thank you so much, Professor Lambert. That was absolutely fascinating. Stunning as always. Just to say to everyone that unfortunately the webinar that we had planned for this Thursday with Professor Shimazaki from Oklahoma on the interactions between strep A and scarlet fever and PANS pandas has to be postponed due to unexpected circumstances. So we will be sending out an email about that. So there is no webinar this Thursday. The next one that we have scheduled is on the 30th of March on Toxiplex, the new test for mycotoxins that has been launched by AONM Labs. So thank you so much again, Professor Lambert, wishing you all the best, and hopefully we'll be talking again soon.
Okay, thank you. Bye-bye.
Thank you. Thank you.